All right, appendicular skeleton. That's where we're going to start today, and then we're going to go through joints a little bit. The appendicular skeleton, as you know, and as we mentioned last week, deals with the limbs for sure, right? The appendages, your arms and legs, but also deals with what we call the shoulder or pectoral girdle, which would be the clavicle or the collarbones, and then the shoulder blades or scapulae. Okay, so again, your patients, when they come in, they may describe issues with their shoulder blade or issues with their collarbone, issues with their kneecap, right? But clinically speaking, you're going to know they're talking about their clavicle or their scapula or their patella. Okay. So anyway, shoulder girdle and pectoral girdle. So these two bones are part of the appendicular skeleton. And then when we zoom down to the hip region, we have what they call the pelvic girdle or the hip girdle. And we'll see that it looks like one group of solid bones. We'll actually see that you're going to have three bones, kind of three pairs of bones fused together. So we'll see that in more detail. So you'll want to know the three bones of the pelvic girdle, the two bones of the shoulder girdle, and then the upper limbs and lower limbs. There's a handful of bones there that you'll need to know. Not very many. I mean, I'm not going to have you know each of the wrist bones. You're just going to need to know that they are the carpal bones. And so anyway, we'll talk about that when we get there. Same with the ankle bones or the tarsal bones. There'll be a couple specific ones you'll need to know. But for the most part, we're just looking at three bones of the upper appendages, three bones of the lower appendages, then a handful of items in the wrist, ankles, hands, and feet. Okay, so we start with the shoulder girdle. Again, scapulae, that's the plural form with the E at the end. One is a scapula, again known as the shoulder blade. One thing that you'll notice as well, different than really a lot of the bones we've seen, but yet in some ways very similar. We looked at the skull bone and we saw that there was like your cheekbone ridge kind of coming across here up on the skull. Remember that zygomatic arch that we called it? That generally when we see some sort of arch or ridge like this, or what they call a spine, you can see them all along the vertebral column as well, right? All those little spines that kind of stick out there. Generally, that type of bony landmark implies that we're dealing with muscle attachment site. So when we look at the scapulae, we see a pretty major, we'll see a pretty major ridge or spine kind of on the superior aspect and the posterior aspect of the scapula. And then the clavicles, we'll take a little peek at those. Not a heck of a lot going on there. Again, this is going to be major site of muscle attachment. They're pretty flat bones. They have a little bit of a curve to them. We do see a couple of joints. Again, joints are going to be named for the bones that make up the joint. So we will see the clavicle coming together with the sternum, forming what we call the SC joint. So keep that in mind as we go along. Again, that joints are going to be named for the bones that create that joint or that articulation. Okay, so we'll just keep her moving. All right, here's a scapula with several bony landmarks. It's kind of like the temporal bone of the skull, just a very dynamic, structurally put together bone. For again, not only do we see the spine coming across or this ridge, we also see this very broad kind of flat surface below that spine. And then we see another kind of grooved surface above the spine, kind of right in here where this blue area is. These are, again, major sites of muscle attachment. You guys have probably heard of the rotator cuff muscles at some point of the shoulder. Next week, when we get into muscles, we'll look again at the scapula, and we'll see that there are 4 rotator cuff muscles, and all 4 of them have their anchor site or their origin on the scapula. So again, it's what they call kind of like a fixator bone. It does a lot of muscles that need to be fixated or stabilized to perform a movement of the humerus or the arm. you know, we definitely need a bone that's got a lot of surface area for a lot of muscle attachment. I mean, really all of these multicolors that you see, these are indicative too, not just of the bony landmarks, but these are the muscle attachment sites as well. So again, you can see that we would have many different muscles attached to the scapula. And generally, you know, the names of these, I told you we don't really get into heavily with bony landmarks, but I do want to mention a couple with the scapula because they do come into play when we look at joints. So first off, I've mentioned it multiple times already today, but this red kind of ridge, this would be the posterior aspect. This would be what you could palpate. You can palpate that bony ridge without too much trouble. If you follow your clavicle around, it just becomes, this is the bony ridge of the scapula, which we do call the spine of the scapula. Okay, so this is called the spine of the scapula. By the way, this is the right scapula. And the reason, a couple ways I know this. First of all, I'm looking at what we would consider to be like the posterior aspect. So when I look at the scapula, I have either what kind of this sharp edge, this border here, or if I come over on this side, I've got another border, but it kind of terminates into what looks to be a little shallow groove or depression. This is your socket for your shoulder. This is where your humerus plugs in, or your upper arm bone. So if I'm viewing this from the back, this area over here would be where my right humerus would plug into. This area here, this bright green kind of neon-y spot, that's what they call the medial border of the scapula. And this is what they call the lateral border. Okay, and then we've got that little shoulder socket or cavity. So anyway, I'm looking at the right scapula. As this spine kind of comes around toward the lateral aspect, we get this purplish jobber. That's called the acromion process, or just the acromion. This acromion is going to be what the clavicle or the collarbone basically articulates with. Okay. So this acromion process right here, if we follow it around anteriorly, this would be the clavicle out here. So the clavicle is kind of a flat surface, along with the acromion process, kind of a flat surface. They kind of glide together when they articulate. So we'll see a joint here coming up shortly called the acromioclavicular joint. They call it the AC joint. That's important because a lot of your patients that come in and have some sort of shoulder injury, they may have some sort of AC separation or an AC subluxation or something like that, maybe an AC sprain of the shoulder. So anyway, the AC joint of the shoulder, and you can palpate, that's that lateral most kind of bumpy spot out here. It's where your clavicle ends and your scapula begins. So if you follow that around, you can feel your scapula. You can palpate it kind of going toward the back. That's the spine of the scapula. Coming forward is the acromion, and then again, it connects with your clavicle. Okay, so that girdle starts, and then this bump in the center, in the medial portion, you've got two big bumps right here. That's going to be the medial portion of the clavicle. That's where it connects with the sternum. Then again, if you follow it laterally, you end up on those big bumps out at the shoulder region. Those are going to be the acromion coming together with the clavicle. All right, so anyhow, so spine and acromion process. And then while we're out there, you know, if we just go a little bit inferior of this acromion and we just drop inferiorly, we end up in the shoulder joint, actually in the socket. This little groove is called a cavity. They call this the fossa. They're interchangeable, really. But this is called the glenoid. They call the cavity glenoid. Okay, so the glenoid is the socket for your humerus. Okay, so that forms your shoulder joint. Notice how shallow that is. extremely shallow. There's nothing really to that groove. So what I'm getting at is it's very easy to dislocate or to sublux, which is in essence the joint goes out and then slightly goes back in. So it's not dislocated, it's subluxed. It just means it's out of place. Dislocated means it's like if this is the socket, dislocated means it's actually out of the socket. Sublux means it's just moved around a little bit. So anyway, we see that a lot with the shoulder, again, because of the shallow nature of that glenoid. And then we'll see that this is called the GH joint, glenoid and humerus, GH joint. All right, so anyway, you've got the spine of the scapula, and then just above the spine, we have the supraspinous area. And then below the spine, we have infraspinous. Remember, supra means superior. Supra, superior, so above the spine groove. Infra means inferior, so we call that the below the spine groove, or the infraspinous fossa. A fossa is just a shallow kind of a groove or depression. And again, it's typically muscle attachment site. All right, and then these two little points, they're just the angles, they call them. They would call this the superior angle and the inferior angle of the scap. And then finally, we have the underside of the scapula. This is the portion of the scapula that would be right up against your rib cage. They call that the subscapular, underneath the scapula. All right, clavicle, not a heck of a lot. We're not even really worried too much about the clavicle. We do have a kind of a thin, the clavicle is pretty flat. It's kind of a little bit of an S shape to it. We do see when we look at it in kind of a horizontal view, we see the lateral aspect that goes out and connects with the acromion process of the scapula. We do see that is thinner than what we would consider to be the medial portion or the sternal aspect. So that chunkier part connects with the sternum, the thinner part connects out with the acromion. So they just call these the acromial end and the sternal end. I've also seen them as the lateral third and the medial third. So sometimes they'll break the clavicle up into thirds. So let's talk about the lateral third, the middle third, and the medial third. And again, the clavicle and scaps are big, so that shoulder girdle is extremely important when it comes to anchoring or stabilizing the shoulder joint. So a lot of these muscles, what we'll see next week when we get into muscles, these are called fixators. They kind of stabilize or fixate the scapula and the clavicle. So when we get any type of action or range of motion out here, we have a nice, sound, stable ground that these muscles are able to move upon. Okay, so that's what the scapula and the clavicle allow for stabilizing of the shoulder. All right, so let's stay in the upper appendage and look at a couple of the bones involved with the arm. So again, when we see the word arm, and really they're talking about the upper arm, and that singular bone is known as the humerus. You guys have probably all heard of that at some point, I would imagine, the humerus. So that's your upper arm bone, and then the forearm is going to be comprised of two different or separate bones. The medial bone, remember we're in correct anatomical position, so the palms are facing forward. We can see his thumb is lateral and his pinky is medial. So this bone that's on the pinky side or the medial portion is called the ulna. And it basically just performs flexion and extension. So just bends the elbow. So the ulna just forms what we call a hinge joint. Whereas this lateral bone called the radius, that's going to also kind of come along for the ride when we do any type of elbow flexion or extension. But the radius is actually going to enable us to do what we call pronation and supination. Basically allows you to radiate or turn your hand and wrist medially and then laterally. Again, we call it supinate and pronate. And then the wrist, we've got those we call carpal bones. Again, you don't need to know the specific names, know the numbers. You do have 8 carpal bones in each wrist. Okay, so 16 total carpal bones. They're kind of arranged in 2 rows of 4. Kind of have 4 articulating with the ulna and radius, and 4 kind of articulating with the metacarpals. And then lastly, we end up with the hand, and we'll see we have what are called metacarpals forming the palm of the hand, and then all of your digits we call phalanges. So let's take a peek at the arm and forearm just in a little bit more detail. I already mentioned the humerus is the upper arm bone. And from posterior view, you can see the ulna is a little bit longer than the radius. The ulna comes up and forms the elbow. Again, you can see it's going to be on the pinky side. So ulna is on the pinky side and is medial. The radius, it's got kind of a little cap over here, and or a little kind of a head with a cap on it. Again, this is going to be a divot or depression. That's going to allow for that kind of pivot or radiating motion that we can perform with the forearm. When we look at the humerus, we do see just a ton of different bony landmarks. Again, several of these are going to be for movement or for muscle attachment. So we can see, again, we would call this the proximal. Zoom in a little bit. So where we have what we call the head of the humerus or the ball, this would be considered the proximal portion, right? The proximal end of the humerus. And then we go to the other end down toward the elbow where the ulna and radius articulate with the humerus. This would be called the distal end of the humerus. The distal end of the humerus. And again, lots of bumps, ridges, grooves, depressions. So we do see quite a bit of spots for muscle attachment. We would see the rotator cuff muscles are all going to be up in this area. We're going to see what we call the deltoid muscle, where we do a lot of our intramuscular injections. A lot of this little purple mark right here is going to be where the deltoid connects. And then the triceps, this is the back of the arm muscles. We've got a spot for the triceps, one of the heads of the triceps. So anyway, a lot of bumps, ridges, and grooves. When it comes to the humerus, I think it's important certainly to know that it's the upper arm bone, or the most proximal of the appendages of the upper arm. Know that it does have a head, which we also call the ball, okay, the head of the humerus. And then the distal portion, we do have a couple little spots here. We've got on the medial portion, we've got what we call an epicondyle, the medial epicondyle. And then out on the lateral portion, we've got another little bump called the lateral epicondyle. But yeah, those 2 little bumps, again, those are going to be major sites of tendon and ligament attachment. Ligaments are going to help to stabilize the elbow. The tendons are going to be from the forearm muscles. So again, we see golfer's elbow or tennis elbow affecting these 2 epicondyles or inflaming them. Let's see. I mean, there are tons of bony landmarks. And again, if you guys are getting into orthopedic nursing or physical therapy or even surge techs, may need to know a little bit more about bones and bony landmarks, but I'm just going to keep her moving because I don't think that's the case for any of you today. Radius, again, this is going to be on the thumb side. So this is the lateral of the forearm bones. And again, we have the little head at the top and then a tiny little neck. Okay, so this would be the proximal portion. So the proximal radius is going to articulate with the distal humerus. And it's going to be on the lateral aspect of that elbow region. Again, we've got a little tubercle. A tubercle is basically a little bump. And then again, the bulk of it is going to be the shaft of the radius. And then laterally, kind of out toward the thumb and wrist area, we do have a little styloid process. So another styloid. We saw that in the skull. We'll see the ulna and radius also both have styloid processes. All right, so the medial bone of the forearm is called the ulna. Now, really, there's several landmarks with the ulna. Issues with my ulna. Get it to rotate a little bit. There we go. Nice. Okay. So the ulna, we're looking at kind of a lateral view of it. So this right up, the radius would kind of nestle right up against this spot here. But right here, this kind of C-shaped jobber, that's where the ulna fits into the humerus. So this little blob here is what makes up your elbow. So your elbow is called, again, fancy term for elbow is olecranon. Okay, olecranon, that implies that we're dealing with the elbow. So yeah, that bump that you palpate is called the olecranon process, or just the olecranon. All right, moving forward, we've got the wrist bones. Again, just know you have 8 of them, and they're called carpals. We're going to move on. And then in the hand, oh, you can see the carpal tunnel. We've got the median nerve is covered up by what we call kind of a sheath, or what they call a retinaculum. It's just basically a kind of a tendinous or ligamentous sheath that covers up and protects a lot of the blood supply and a lot of the nerve flow and some of the bones. So the median nerve is right down the middle, kind of feeds the index finger and middle finger a little bit with sensory and motor. So when there's pressure put on that median nerve from some of these tendons or misalignment of some of these carpal bones, it can put pressure on that and then cause some tingling or some sensation issues, or maybe even movement or motor problems. Okay. So anyway, that's just showing you the carpal tunnel. And then lastly, the hand itself, we have what are called metacarpals. And the metacarpals, again, they make up the palm of the hand, and they just name them first, second, third, fourth, fifth. That's it. So you have the first metacarpal is going to be the thumb, and then the fifth metacarpal is going to come out to the pinky side. And again, these are the bones of the hand. We oftentimes, again, if you work in a GP office, general practice, you may have somebody that comes in that maybe punched a wall or got in a fight or hit something, right? And almost invariably, we'll see some sort of a fracture of the distal portion of one of these metacarpals. So when someone says they broke their hand, it's a metacarpal, likely that they broke. And then lastly, we have what are called the phalanges. Oops. The digits or phalanges are the last portion. And the thumb has 2 phalanges, and then the rest of the fingers have 3. And the phalanges are named same with the metacarpals, first, second, third, fourth, fifth. But since we have extra phalanges, they do label them as either proximal or distal. And then for the case of the fingers, we have what's called a middle phalanx. So the middle bone of the middle finger would be the third middle phalanx, for instance. All right, let's keep her moving. Go through the pelvic girdle for just a couple minutes. Again, we do have 3 bones kind of fused together, forming that pelvic girdle. The largest of the 3 is called the ilium. Okay, the ilium, I-L-I-U-M. We'll see ilium again later when we deal with the digestive system, one of the sections of small intestines is also called the ileum, but it's spelled I-L-E-U-M. So, and just to add more confusion to already murky waters. So anyway, the ileum are in essence, these are what you would know as your hip bones. You can see that they make up the majority of what's palpable of the hips. We also notice that the ileum comes in and forms a joint with, you remember what this bone is called? This last little section, or one of the last sections of fused vertebrae, we call this the sacrum. So we see the sacrum and the ileum come together and form really two joints, right? Like a right side SI joint and a left side SI joint. So they refer to this joint right in here as the sacro or sacroiliac joint, SI joint, sacrum and ilium. This can be subluxed very, relatively easily. We see it, people that come in, they maybe were going down some stairs and maybe they missed one, or they stepped off of a curb funny and it kind of jostled their hip girdle a little bit, or pelvic girdle. So that could cause a minor subluxation of this area. And again, we've got a lot of your lumbar nerves coming down. Their sciatic nerve kind of passes through a little notch in here. So anyway, this can be a site for issues potentially regarding hip and low back pain. All right, so anyway, the ileum, they call this the iliac crest, this big portion. And again, that's your hip ridge. Then we do have a couple little bumps out front, kind of the point of your hip. And again, they have long names, ASIS, we abbreviate it. But we're not going to get into depth with that. All right, next bone up is going to be the more anterior, or the most anterior of all three of the bones of the pelvic girdle. We call this the pubis bone. The pubis bone. And the pubis bone comes together with the other pubis bone and forms a small joint right in the middle. We call a pubic symphysis. And again, this joint is very slight movement to it. It has very slight movement to it, which is good, especially for a mother that's about to deliver a baby. It allows for the pelvis to spread a little bit, makes this pelvic opening a little bit bigger for baby to pass through. So anyway, the pubis bones are in the front. And then your butt bone is also known as your ischium or ischium. Ischium is the proper pronunciation. It's an IS and then a CH makes a K sound, ischium. But you will hear it pronounced ischium as well. And this is your butt bone. This is the bone you're sitting on, your ischium. And again, we've got a groove where the sciatic nerve kind of passes through. So anyway, that's a site of potential pain from sciatic. Okay, so anyway, the ilium, you can see tons of bony landmarks. And again, you really just know the iliac crest, I would say, out of all of these. And again, this whole area they call the greater sciatic notch. That's where that sciatic nerve passes through. Then the ischium or your butt bone. Oh, by the way, when we look at the pelvic girdle or the hip girdle, we also have all three bones coming together and forming this socket. So this socket right here is the hip socket. This is where the head of your femur is going to go. Notice it's a lot deeper than that shallow glenoid fossa that we saw of the scapula. So in essence, the scapula and the glenoid fossa of the scapula form the socket for the shoulder. The ilium, ischium, and pubis form a socket for the hip. And this socket is called the acetabulum. Here's the spelling of it. A-C-E, ace, and then tab, T-A-B, and then U-L-U-M. They pronounce that acetabulum. That is the socket for the hip. That's the hip socket. Okay. So this is where your femur head is going to plug in. Acetabulum. And all three of these pelvic bones converge and form that acetabulum. And then lastly, the other thing I want to mention real quick, you've got a large O hole here. So if it's a hole in a bone, they call it a foramen. So we do see a large foramen or large hole there. It's the O foramen, called the obturator. Again, not probably important, but you may see that term occasionally. Here's the obturator foramen. That's the O foramen, the big hole. Okay, male and female pelvises, we do have a slight difference between the two. Certainly, the male pelvis has a smaller pelvic inlet, smaller opening than the female pelvis. The female pelvis also has more of a scoop to it than the male pelvis. The other thing we see where the pubis bones come together, the male, we see this pubic arch, it does form an angle, and that angle is going to be just slightly less than 90 degrees. This is helpful, like if we find skeletal remains, right? Is it a male or a female? Oftentimes we can tell just by, if the pelvis is there, we can tell by that. That's going to be the most accurate way to determine male versus female. There are some skull features as well that we can use to determine male or female. We can also determine age or approximate age of skeletal remains based on some other factors too. But we see that pubic arch, we call this the pubic angle as well. With a female, it's going to be 90 plus degrees. With a male, it's going to be less than 90 degrees. All right, so we're just about done with the skeleton. We do have a couple more bones to do. Obviously, we still need to do the lower appendage. So we're going to look at the thigh and the lower leg bones, and then we'll look at the ankles and feet a little bit. Okay, the largest bone of the body, of course, is called the femur. All of you have heard of that bone. You've probably heard of several of these bones at some point or other in your lives, but definitely the femur. The femur, again, largest bone of the body. Femur can withstand approximately, a healthy femur, an adult femur that's done growing, can withstand up to 2,000 pounds of pressure or force before it'll break. So the femur is extremely difficult to break, at least at the shaft or the diaphysis. Now we do get what we call the neck and the head of the femur. That area, the proximal aspect, that does have the tendency to become more porous, especially if someone does have osteoporosis. So usually if grandma falls and breaks her hip, it's actually none of those things. Grandma probably didn't fall and break her hip. Grandma's neck of her femur broke and then she fell. Because these become so porous that even taking a step up onto a step stool or onto any movement that requires a little bit of force or pressure on this area, if that bone is porous and brittle, it'll break and then the person will go down. So they don't really break their hip at all. Their hip is considered to be this ilium, ischium, pubis region. Those are extremely dense bones. They're very difficult to break. That'd be a broken pelvis. We see broken pelvises usually in some sort of a fall or usually a fall from a substantial height, not standing here and falling to the ground. Okay, that probably won't break your pelvis. You could get a little bit of an issue out here, but motor vehicle accidents, we see quite a few broken pelvises. Yeah, yes. Especially like a T-bone job, somebody T-bones somebody We had one, and the guy ended up passing away, unfortunately. But he was the passenger in a car, and the car was T-boned, and he was brought to the ER, and we thought that we could. I mean, he seemed okay. You couldn't see any injuries really, but he was losing blood internally. So we found down in here, his pelvis had basically shifted, probably 3 or 4 inches, and then shifted back. And when it did that, it severed a little artery that comes down. It's what they call the inguinal artery branch down in this area. So he was bleeding internally heavily, and they got that somewhat stemmed, I guess, the tide stemmed or whatever. They got some of that bleeding stopped, but he still died. And when I was working at the coroner, I got him when he was at the coroner's office. I wasn't at the hospital, but we can tell based on what limited information we would get from the hospital, as well as what the autopsy revealed. We could pretty much put 2 and 2 together. But he had an afro. He had like an 8-inch afro. It's huge, right? So we were working on him, doing the autopsy on him, and we found where the side, where the door shuts, I forget what they call it, but anyway, where the door shuts, that hard bar whacked him right in the head, and it put a depression, basically crushed his skull, and that's where all the bleeding. He died from that. He didn't die. And they didn't know this at the ER. They had been working on all this internal bleeding here. If they had found that, they might have been able to trepanate him, or, cut that, basically saw a little hole in his skull to allow that pressure to leave. But they didn't know. They didn't think to look, because he had all of his issues were here. His scrotum, seriously, was like the size of one of those skulls, because it was engorged with all the blood. That was one of the crazier autopsy things.
Motorcycle accident the other day with the internal bleeding in the head.
Did he live?
I hope so.
Yeah.
He's a nice guy. He was completely
Oh, he was conscious.
awake and aware.
Yeah. You have a headache?
No, yeah, he was talking to us and everything.
Huh.
No discoloration. It wasn't until we sent him over to imaging that we saw it.
Yeah, you just don't know. Like motor vehicle accidents, it's hard to tell sometimes where the problem is. And there's a problem because their vitals are not doing so hot. But yeah, when we autopsied them too, they had, I don't even know, several rolls of gauze were in his guts, because they were trying to get all that blood soaked up that was just pouring. They finally got that stitched, but he had lost too much blood anyway. But what had happened was, this is what killed him. The brain, just all that pressure on the brain brought his vitals down, and he died. And he was with his fiance. He was like 26 or so. He wasn't that old, but he was with his fiance, and they were leaving like a tailor shop where they were getting fitted for their clothes for their wedding. And they had, I think, 3 or 4 kids already between the 2 of them. So yeah, there's some tragedy certainly that went with it. Well, there's always tragedy when somebody dies, but well, we're not doing serial killers today, but we still won't ever get away from talking a little bit about the realities of death, right? That's what you guys are working in healthcare. You're going to have to see it and deal with it at some point. All right. So lastly, so anyway, femur, again, largest bone of the body. Again, we've got the head up at the top, and then the neck here. This neck area is what typically becomes most porous when we're dealing with osteoporosis, and this is usually what breaks. Again, a lot of muscle attachment site. And then the tibia or the shin. And the tibia is going to be the medial. So it's kind of like the tibia is like the ulna of the lower body. Remember, the ulna is medial. Tibia is going to be medial as well. This little bump down here, this brown bump, I don't know if you guys can see it where you're, I'll turn it over. It's upside down now, but this brownish bump, that's what you've known in the past as your ankle bone. That's that hard kind of ball on the medial surface down by your ankle. That's actually the tibia. Okay. On the inside of your ankle, that's the tibia. They call it a malleolus. It means little mallet or little hammer. Okay, so the malleolus, the tibia, by the way, too, is weight bearing. So this bone is where all of the weight from your femur and down to your tarsal bones or your ankle bones, all of that weight is bearing down on the tibia or through the tibia. The lateral lower leg bone is called the fibula. And again, just like the tibia, you have that kind of bump out on the distal lateral aspect toward your ankle. That's, again, not your ankle bone. That's actually part of your fibula. They call that the lateral malleolus. The fibula is non-weight bearing. So what that means is if I break my fibula, I could probably be put in a walking cast and walk around and be fine because it's the tibia that bears the weight. The fibula, in essence, is there as a vestige. It's a kind of a leftover bone, but it's also there as, again, a lot of muscle attachment and ligament and tendon attachment. And then finally, we get to the ankle bones. The ankle bones are called tarsal bones. Again, generally, I wouldn't have you name these bones. There are a couple, though, that I think are important for you to know. You have 7 tarsal bones. The first one that I want you to know specifically is what we call the talus. It's kind of like the word talon. Talon is the talus. The talus is what the tibia is sitting on or articulates with. So you can see the first bone of the tarsal group is called the talus. I'm going to get into a lot of alliteration. The distal tibia articulates with the talus. Okay. Distal tibia articulates with the talus, or articulates with the tarsal known as the talus. So even more alliteration with the tarsal thrown in there. But anyway, the talus and the tibia articulate. All right, and then just a little bit more distal or further away, we end up with what we call the heel bone or the calcaneus. So your calcaneus or heel bone is also technically an ankle bone. It's one of your tarsal bones. Okay, so tibia, then the talus, then the calcaneus. Calc means stone or rock, like calculus, you're counting stones, in essence, calculator. In the old days, they used stones, right? And that for currency, different types of stones. So anyway, calcaneus. The rest of them you don't need to know. Just know those two for sure. Talus, calcaneus. Again, know that there are 7 of them. And then, so those are tarsal bones. So your foot bones are called metatarsals, just like your palm of your hand were metacarpals. Your foot, those are called metatarsals. And again, you know, just like your fingers, your toes are also called phalanges. One is a phalanx. Multiples are phalanges. And same descriptors, proximal phalanx, distal phalanx, so the first toe, and then proximal, middle, and distal phalanges of the second toe, and so on. So just phalanges, you've got 3, 6, 9, 12 times 4, that's 48. And then 2, 4, 6, 8. So 56 of your 206 are just fingers and toes. That's a quarter of your skeleton is just fingers and toes. So that makes it easy, right? And then you throw in 30 bones, make up the wrists and the ankles. Now we're all the way up to 86 bones just in the wrists, ankles. Then we throw in metacarpals, metatarsals, 5, 10, 15, 20 of those. Dang, yeah, we're up to 50 plus 58. That's 108 of the 208. So over half of your bones are just wrists, hands, fingers, ankles, feet, toes. That's a lot of bones. Just so I mean, knowing 206 bones isn't that hard, really, when it comes down to it. 24 ribs, right? So now they're done. 24 ribs. Done. So I mean, you can bunch them up and get pretty far with bone count. All right, let's look at joints for just a few minutes. Foot, feet, we already did the feet. So joints, just again, I'll only spend a couple minutes and then we'll wrap it up. Joints are classified as either having no movement, a little bit of movement, or free range of motion. Most of the joints that you know before you ever came in here were going to be that free range of motion, right? Your elbow joint, your hip joint, your knee joint, your wrist joint, whatever. Those are all full movement. Okay, so joints with no movement are going to have a couple of, there are more names to classifying joints other than no movement, some movement, plenty of movement. So the kind of the root for joints is Arthur, right? A-R-T-H-R. You've heard of arthritis, right? It means inflammation of a joint. So A-R-T is oftentimes, or A-R-T-H, that implies we're dealing with a joint. And that is short for the word articulation, right? So articulation means joint. So Arthur and the word articulation just mean joint, okay? So whenever we say articulation, we just mean a joint. And a joint by definition, remember, is any two bones coming together. Okay, so two bones coming together make a joint. Okay. And now some of these bones that form these joints we know are immovable. So we'll go through we'll go through more terminology coming up. Let me see. Here we go. So bones with no movement are called S-Y-N, arthrotic or synarthrosis. S-Y-N and then A-R-T-H-R. O-S-E-S. Syn. Syn means same, right? Like a synonym. Okay. Synarthrotic means basically same joint. For us, it means that it's an immovable joint. These are going to be fused bones. So functionally, we call these synarthrotic, amphiarthrotic, and diarthrotic. Functionally. Structurally, they call this one fibrous. A fibrous joint is also synarthrotic and is also immovable. Fibrous just means there's fibers in between. And again, the sutures of the skull that we looked at last week are going to be your synarthrotic fibrous, immovable joints of the body. There are a few others, but for the most part, if you can associate immovable joint and suture, you're doing pretty good. Hey, a couple of other ones that I mentioned, or that we'll mention. One's called a gomphosis. If you're going into like dental hygiene or something like that, dentistry, you would definitely need to know that. But where each tooth comes into either the maxilla or the mandible, that's a joint as well. We don't count, it's funny because they count that as a joint, right? A tooth, which is bone, connecting to, you know, the jaw or the upper jaw, the maxilla, the mandible. But yet we don't count the teeth as part of the skeleton. Like out of that 206, the teeth aren't, you know, part of that. So, but they do make up a joint. So anyway, they call it a gomphosis.
Early doctors wanted to make sure there was a difference between dentists and orthodontists.
They did, absolutely. Yeah, for sure.
They didn't want to practice.
We don't want to be no, we don't want to be associated with those
I don't do that, guys.
guys. Again, right where the first pair of ribs joins the manubrium of the sternum, also considered a synarthrotic joint. They call it a synchondrosis. Again, it just means same cartilage at that point. Like I said, if you can remember that the skull sutures form the immovable joints, then you're doing just fine. Then lastly, we've got what's called a syndesmosis, another type of joint. It's basically formed by this connective tissue sheath, which it's a ligament. Remember, bone and bone coming together is a joint. The tissue connecting a bone and a bone is generally going to be ligamentous. Right? Bone to bone is ligament. We do see cartilage in some joints, certainly, right? Like the vertebral column, we see cartilage there. All right. All right, and then the next batch are called amphiarthrotic. Amphi is like an amphibian, right? It can breathe in water or out of water. So amphi means slightly or partially, somewhat. So amphiarthrotic are slightly movable. And one of the key ones that we see, and these are called cartilaginous joints. So structurally. So immovable joints are called fibrous joints or synchondroses or synarthrotic joints, I should say. Cartilaginous joints are slightly movable. So we see this pubic symphysis, and then we also see the intervertebral discs. So between each vertebra, you're going to have an intervertebral disc. These are going to also be considered amphiarthrotic or slightly movable joints. And then the last big batch are called synovial joints or freely movable. Synovial or freely movable. Okay. These are the rest of the joints in the body. These are the ones that we deal with in extreme amounts, right? The knee joint, the hip joint, shoulder joint, elbow joint, wrist joint. Heck, even between phalanges, it'd be like an interphalangeal joint. In a synovial joint, there's always going to be ligaments involved, or there are going to be ligaments. Ligaments provide structural support, stability. Synovial joints are also going to be contained or surrounded with what we call a capsule. Called the joint capsule or an articular capsule. But yeah, the synovial joint. So all of your movable joints, even like I say, even between your each phalange or each phalanx, your TMJ, right, where your mandible meets your temporal bone, that's a synovial joint. So all of these movable joints are going to have a capsule around them. Why do they have a capsule around them? Does you have any idea why we would want to wrap up this joint in a capsule? Think of it as like almost like a membrane.
Cushioning.
Oh, maybe some cushioning, sure. Usually cartilage will provide that inside the capsule. Well, there's going to be fluid in there. It's called synovial fluid. It's very viscous or extremely slippery. So what this capsule does is it keeps that oil contained. But, we don't get a blood supply. So this capsule keeps blood out. That's great most of the time. And that can be a problem if I've got some infection or I've got an injury or something going on there, a tear of soft tissue. Yeah, good. The rest of it goes, the rest of these go through some of the different joint, movable joint or the synovial joints. It goes through different types of synovial joints. We have what are called gliding joints. Gliding joints generally are going to be two flat surfaces kind of gliding across one another. A hinge joint is just like it sounds. It's like a door opening and closing. A hinge joint just moves on one axis. Again, just like a door, it just opens or closes. So the hinge joint, we think of like the knee and the elbow, especially. Finger joints, those are all hinge joints. They just move in one plane. Pivot joint, we see those at the atlas and the axis, so those first two cervical vertebrae allowing for rotation of the head. Pivot joints. Condylar joints or a condyloid joint. Find this typically where the carpals meet with the ulna and the radius. Then this is a special one called the saddle joint. This allows for opposition of the thumb. So this one we find between that first metacarpal and one of those carpal bones. So the first metacarpal articulating with one of the carpal bones provides us what's called a saddle joint. So it looks kind of like this. It's like a saddle, right? You got the horse and then the saddle on the horse. What this allows for again is opposition. And opposition of the thumb is your ability to touch your pinky with your thumb. We're the only mammals that have opposable thumbs. So like a chimp or a gorilla, they have hands that look a lot like ours. They have really long thumbs for one thing, but they're for like grasping stuff. They say that the adaptation by primates of having an opposable thumb is what led to tool making and a lot of stuff that certainly makes humans different than any other animal. Not that that's good, it just is a fact. Good, bad, or indifferent, we are definitely different than other species of animal. I don't think animals worry about bills or. All right, ball and socket, those are the most range of motion. Okay. Unlimited range of motion practically with the ball and socket joint. And you think of the head of the humerus going into that glenoid fossa or glenoid cavity, and then we think of the head of the femur going into that acetabulum, the ball into the socket. Okay. And then the knee joint, it gives us a little bit of a breakdown of the knee joint. Okay. Again, it's very commonly injured. You can imagine it takes a lot of force and a lot of twisting and turning and torque and torsion. Okay, so we do have multiple ligaments to help to provide some strength and durability to that knee joint. Now, laterally, over here, laterally and medially, we have what are called collateral ligaments. So we have what's called the lateral collateral ligament. We call it the LCL. That's going to be the fibula coming together with the femur. And then on the medial portion where the tibia and the femur come together, we have what's called the medial collateral ligament, or the MCL. This gets sprained quite a bit. MCL sprains come into the office frequently. Again, that's on the medial portion of the knee. So just a slight kind of planting your foot and then twisting of the, so if this down here, the tibia is planted, but my femur does any type of twisting action, that could definitely lead to some issues with either of those collateral ligaments. More specifically, though, we have what they call the ACL, anterior cruciate ligament. Okay. Cruciate means cross. The anterior versus posterior, that has to do with where the ligament is on the tibia. They call this the tibial plateau. What we'd call it like the proximal portion of the tibia, the top of the tibia, that's called the plateau of the tibia. Okay, so the anterior portion of that plateau is where the ACL plugs in. And then it comes over onto this lateral condyle of the femur. And the PCL plugs into the back or the posterior aspect of the plateau of the tibia, and then just kind of comes over here onto the lateral or the medial condyle of the femur. And then these little guys are called meniscus, or one is called a menisci, or actually one is called a meniscus. Multiples are menisci. So the medial meniscus, that's cartilage. That's what's going to provide that cushion. Then we have the lateral meniscus over here. Typically, when someone has cartilage issues of the knee, it's going to be one or the other, or maybe both of these menisci. And remember too, this whole joint is encapsulated. So if there's a tear or an issue or arthritis, anything in this capsule, it's going to be very difficult to get it healed. We can nourish some of the features of the capsule. Okay. There are some pores in the bone that allow for some blood supply, primarily micronutrients and gases. But when it comes to actual material to fix a tear, the pores and the blood supply don't cut it. So we usually have to do arthroscopic type surgery. And then we also have, this is called articular cartilage, the ends of your bones. So yeah, if we have degenerated articular cartilage or inflammation in that cartilage, that's called arthritis. you can see, you know, why obesity is a major issue for the knees. This is cushiony cartilage here called articular cartilage. They won't let me blow it up, but this right here is articular cartilage. If I add weight onto this, you know, that weight is bearing down on my feet, all the way down to my talus bones, but also the knee joints are getting a lot of that weight bore down on them. And so again, we can get some serious arthritis occurring in the knees due to excess weight having to be carried around. So that's it for joints and for the skeletal system. Next week, we'll get into muscles a little bit.